Hello, everyone, and welcome back. Today, we're going to be going over the trauma case that I posted last week. So, here's the initial PA we took. You can see apically everything looks great. However, the coronal aspect on 9 and 10 have seen better days. When we look at the cone beams, you can see that there is a fragment on the palatal of number 9, along with the pulp exposure. Number 10, no fragments there, but the pulp was also exposed. And visually, you can see that because, well, they're both bleeding. Now, from the buccal side, it wasn't as bad as I thought it was going to be. 10 looks pretty bad there, but there was more tooth structure once we actually got in it, and it really wasn't that bad of a case. So, first thing we need to do, get that fragment out of there after we get him nice and numb. It popped out pretty darn easily, thankfully. I didn't have to get anything too fancy there. It was really just held in place. Now, there is a small vertical line running. You can see underneath it. That's the one thing I'm concerned about on this tooth, that it might end up needing a root canal. I was able to cover it all really fast and get everything looking good, so I'm not too worried about it. We'll talk about that later. As far as the treatment options here, I talked with the mom and the son. He's 20, by the way. Oh, I forgot to say what happened. Poor guy was playing football with his friends and decided to dive for a pass and ran into a fence. Now, he did catch the ball. He did make sure to tell me that. But unfortunately, his teeth took the brunt of that injury. We did talk about doing a root canal versus direct pulp cap. And because it was only 12 hours and he's 20, I feel confident that a direct pulp cap is going to be a great option for him here. With the way that we now bond teeth, it works a lot better. So what I did is let the bleach soak on there for about a minute. That was that speed up time. And you can see the stumps are looking very healthy, no more bleeding there. So this is kind of a modified Cvek Pulpotomy. I just got rid of the stuff at the top that was inflamed. And as far as root canal versus direct pulp cap, indirect pulp cap, there was like 4 hours on this at the AAE, if you guys were there in LA. It was some of the most interesting stuff they had. And the conclusion that most of us, I think, took away here, if you can keep the tooth alive, it's probably worth doing. If they are under the age of 30, a direct pulp cap seems to have really good results. If they're over that, then we start to see it fall off. So because he was 20, because it was a quick one, I decided to go ahead and go with the direct pulp cap here. Now, I did use bleach instead of EDTA. Sometimes you'll use EDTA to encourage the stem cells to start waking up. That's one of the cool things that EDTA does. But because it had been exposed to the mouth for 12 hours, 12, 14 hours, whatever it was, I wanted the antibacterial effect of the bleach. And you can see it's looking really good. The direct pulp caps, a little bit of bleeding there. That's totally normal. And what we're doing is just using BC Putty directly on top of there. So it's a very predictable procedure, thankfully. I wanted to add a little bit more just on number 9, because there's still a little bit of bleeding here. But this is a great material, because once it's in place, what you can do is just wipe it off with a dry, clean cotton pellet, which I'll do here after I do one more little layer. This stuff's expensive, so once you get it out, you can't put it back in, so may as well use as much as possible. But you can see I'm just taking a dry, clean cotton pellet and kind of smoothing off any excess, and it's stays in very nicely. So if you haven't done one of these, it is a pretty simple procedure. We've talked a bit on here. I think this is more via comments, but if you're a general dentist watching this, BC Putty is incredibly expensive. It is by far the best material. I'm not sponsored by Brasser, but would love to be. So if you know anybody, help me out there. And it works great. The problem is it does go bad pretty darn quickly if you're not an endodontist using it all day long. So for most general dentists, pediatric dentists, I found that biodentine has a much longer shelf life because it keeps it separate in a powder liquid form, and you just triturate it like you would a regular amalgam capsule. It works great. So that would be, for the people asking about that would be my recommendation. All right. What we're doing here now is I'm getting ready to do the restorative. And this is what I learned at ULP's composite clinic how many years ago now, that it's much better if you hide the transition. So I'm making almost these little divots kind of randomly up and down on the facial. It'll also give me more to bond onto. Now, this patient I was seeing as an add-on. It was kind of insane. I had to start, finish, and it was all over the place. So what I did here is I got him stabilized. This part right here, after I do the this is the self-etch stuff. I didn't want to use the total etch because of it was being so close. After light curing that, you then just put a little bit of flowable on top of there. And this then stabilized him while I could go finish the other tooth. So I'll show that x-ray as well. As far as I did do another molar root canal while this guy was just hanging out. I don't love having root canals, or I don't love doing 2 root canals on two different people at the same time. It's just very stressful. So this is about 35 minutes later. We are now coming back, and he's been stabilized, and we're going to start building up the teeth here. So at this point, I'm looking at the two teeth, and I think I'm going to start with 10 just because it's a little bit smaller. When you're using the Bioclear system, you can do every other tooth, but you can't do them side by side at the same time. So that's why I'm going to be doing one tooth and then the other. We are going to blast off all the lovely biofilm on there. This is really key to make sure you have a nice seamless transition. So if you haven't used this, it is a very nice tool. I do have one in each room. I know I was in Chicago hanging out with my buddy Logan, and he only has one, and his staff were like, "Well, how many do you have?" I think he might murder me after the weekend in Chicago because I kept telling his staff all the cool things we do, and now they want to change all those things as well. But anyway, there is a small divot right here on the buccal where it almost had like decalcification. I don't know what the teeth looked like beforehand, but this is a weird fracture. The right on the distal facial line angle, there was almost another chip that went out of that area, and it was kind of decalcified. So that's why I went back in with the burr just to clean that up. And like I said, we'll start over on the lateral to start the process of building it up. Now, these are the Bioclear small universal, and that's really what I tend to use. It's the A103 for those of you keeping track at home. And they tend to work really nicely for laterals. On some female patients with very curvy teeth, I'll switch over to there's a 1 millimeter curve that's actually designed for diastema closures, but I find that it matches pretty well. For most, males tend to have slightly squarer teeth, and I like the 05 curvature rather than the 1. So they make so many different types of matrices and bands, and if you haven't taken their classes, I highly recommend it because they are really cool. It is expensive, I'll tell you that right now, and it is a little bit tedious to get set up. The cool thing is, once you get it set up, you'll see it's a very easy process. So we're going to do the total etch here. Sorry, there are some cuts in this video, mostly the 30 minutes when he was just chilling there. And then there's, this was turning into it. This is already a 30-minute long video. So if you guys stick through and watch this entire thing, I love you. If you really wanted me to keep in some of the downtime of like light curing and stuff like that, let me know, but I'll still put the total times in there. Just the video was getting a little tedious and long, and I don't want to be just droning on and beating dead horses like last time. So as far as the rest of the process, I have been corrected. This cool thing, they change the protocol all the time because they're learning new things. So you air thin the bonding agent, and then you go in and actually light cure it before you put more bonding agent in, and that's what we're doing here. Once you put the bonding agent in for the second time, it's important to air thin it again so that it helps. This almost helps lubricate getting the composite down into the areas around where the matrices are. And you'll notice I am using my left hand to stabilize everything. If there's a better way to do it, let me know. But I found that this seems to be the best way for me to hold everything nice and still. And what we're doing here is we have put a layer of the bonding agent in. We're now putting a layer of flowable heated composite. So all of the composites here have been in the heater. We then go right in with the packable composite. And it's unfortunate that 3M, I like 3M as a company. They make great products, but God, it's expensive. And I've tried it with other composites, and it just really doesn't work. So once again, not sponsored by 3M. I know Dr. Clark is, and that's why he's recommended it. But this material just works so stinking well with the heated composite. It's way better. So that was an entire compule. And what I'm doing here is trying to just get as much of the shaping held in place so that I don't have to do as much after. And you can see it already kind of looks like a tooth. I'm using the glick to hold the bands in place, almost creating like that fishbowl effect. Or is that what he calls it? Like a cram? I don't remember. You make it so it's all sealed. Now, I did notice that there is a little bit of a deficiency on the facial margin here. So what I'm going to do is tease back the plastic and add. There's right where my glick was, I pushed a little too hard. I probably could have made it work, but what I found, if you want to try, I'll put a bunch of tips up as we're doing this when I edit the final video, but I find it very helpful to over bulk, especially in the facial direction. For some reason, all the composite goes to the lingual. There's never a problem with lingual composite. You'll see I have to remove quite a bit. But on the facial, the system tends to be a little, it tends to want to flow, and that's probably because it's heated and because of gravity would be my guess. But you can see there is a deficiency there. I also had a hell of a time getting these damn bands off. Usually these matrices pop off, no problem. So do not think this is, this is normal. Usually it's very easy to remove these. What happened here, I was looking back through the video, when I put the bands on, or the matrices on, I overlapped a little too much in the buccal area, and the composite kind of bonded the two pieces together, and that's why it's not great. So you'll see it takes a long time for me to, and for some reason I had the problem with 9 as well. The final result is great, but this is a very tedious process sometimes. And like I said, usually this just teases out and it's super easy. But I was just not having a fun time today with this sort of thing. So you can almost see the little divot on the facial there and this is a very useful angle where I'm looking at the surrounding teeth and kind of seeing where their emergence profiles are. And I can see that I am going to be slightly under. And so tip number 1, over bulk, especially to the facial when you're using the system, because it's very difficult to add more composite, especially when the damn bands don't get off, as you can see. But once you've had that, then you can kind of shape it using the different burrs, which is what we'll get into in a little bit here. The beautiful part about this system is the incisal edge definitely is a mess. Like it's all up on there, but we do have great shapes already at the gingival embrasures, which are some of the hardest ones to shape. So I don't have to do as much work in the hardest area. I just have to kind of get the more coronal aspect looking beautiful. So at this point, I'm making sure that all the plastic is off. You can clearly see where I'm a little under right in that area where I'm right where the plastic is. Obviously, we're not going to bond to the plastic, so I need to get all that off. And yes, sometimes it is this tedious. For those of you who don't remember my rant about general dentists being upset of, oh, you're stealing production from us when you restore the teeth. No, I'm not. This is how much time and energy it takes to make them look beautiful. And I could be doing a lot of different things instead of doing the composites here. Now, I really enjoy restoring trauma cases. It's one of the more artistic things that I get to do. And so I love it. My team, whenever they see that thing come out, they know it's going to be a lot longer procedure. And they're just like, oh, I can't believe I have to do all this. But I think you'll all agree the final result is well worth the effort. So added a little composite there just to bulk it up. Quick light cure on that. And then what I ended up having to do is, normally at this point, I don't have to do too much. I can move right on to number 9. But because these silly matrices did not want to get out, I ended up having to start some of the shaping. So I wouldn't normally do this, but because of the matrices, I had to remove some. So the next tip is these wheel burrs work great for the incisal edge, but make sure you keep it long until you're finally done. So you'll see this tooth is about as long as number 8. And I did that on purpose. It's very easy to remove more, but you can't add more without having to go through this process all over again. It's just a pain and it's not as strong and there's lots of issues with it. So what I'm now doing is using my big prep burr to shape kind of the first emergence profile as it comes out of the gingiva. And I'm using the surrounding teeth to get the rough idea of it. Now, once I do the actual final shaping, I take the rubber dam off. We do everything with the patient, and I'll be looking at his face and how the teeth kind of come together as well to make sure they're all in alignment. But because I need to get these stupid matrices off, I had to start and remove a little bit more. So this wouldn't be how I would do it normally. Normally, I would be moving on to the next tooth right here, but I needed to get rid of those spots where it was kind of touching. So pleased with that. And now I go on to the lingual side. So when you're doing these, most of the effort really needs to be focused on the buccal because that's where people see everything. The lingual, though, you do have to shape at least a little bit to make it look good, but I find that the lingual shaping really does not take long at all to do. And the same thing when you go to polish the lingual, I'm going to just do a quick polish on it. I tend to like to leave anything in occlusion actually slightly rough. It almost seems that if you leave it rough, it creates almost an abrasiveness. And so if there's any small little, areas where there's interferences, it actually will sand itself down. It kind of works like sandpaper, which is pretty cool here. I'm still fussing with these dumb matrices. I don't know why they were so hard. If anyone out there is a Bioclear expert and can help me, please let me know. Usually these pop off right away, but I seem to have problems buccal, palatal, mesial, distal, just pretty much circumferentially at this point, one might say. And it almost reminds me, if you, I'm a contact wearer and have been forever, it almost reminds me if you break a contact in your eye, how the bulk of it will come out in one piece, but you'll have that one little fragment that just sits in your eye all day long until you finally blink it out. That's what this felt like. So I very much felt the pain here because I've had that with my contacts and I'm now having it with my teeth. So obviously this does seem tedious, and it is. It's in order to make teeth look perfect on the anterior in particular, it is very hard to do. This does take time. I do still love this system, even though it is tedious, and I do find that it makes me look like I actually know what I'm doing. I'm not a general dentist, I'm not a restorative dentist, and yet I'm able to create these really pretty looking restorations, and I credit the Bioclear system for all of that. Now, what we're doing here, when the trauma occurred, there's this really weird kind of chip that was taken out on the distal buccal of number 9, and the gingiva had grown in there. So I'm using the Alpha to system barbecue it out and get that, excess tissue out of the way. This is where a laser would obviously be nice, but this seems to work pretty well. I don't know why it broke in such a strange manner. And then this is where we do have to do quite a little bit excess here on the palatal. He did start to feel this, so had to do a little bit of a palatal injection here. Sometimes I like to even go back in if there is a bleeding spot and just do a couple like PDLs, because the epinephrine inside there will help with the clotting as well. Helps with your hemostasis. You don't have to do quite as much with either the Alpha or with Cutrol, whatever your system is. And you can see the palatal definitely was pretty pissed off, and that does make sense. There was a crack down there. Now, I'm not going to be able to predictably get composite down to the extent of the fracture on the palatal. I do know that. I guess I really could if I wanted to by flapping it and pulling back all that palatal tissue. But if you ever had to repair anything on the palate, that tissue does not play very nicely with everything. So I ended up just leaving it where it is. The beautiful thing about palatal tissue is it heals. It is extremely keratinized. It is okay if there's a little bit of an overhang or if it's not perfectly smooth. On the buccal, however, that would look terrible. It would immediately be red, puffy, and look awful. So on the palatal, you can get away with a little bit more than you can on the buccal. So what we're doing now is finishing up with placing the matrices on number 9. As you can see, they're fitting really nicely. So if the teeth still have contacts like these do, I find that I don't often have to use a wedge or anything to hold them in place, and that's the case here. And that's the nice part about this system is they're a little bit stiffer, so they hold in place really nicely, especially if you can get them underneath the gingiva. It almost locks it almost perfectly in place. If the teeth are really broken down or if there's gaps, that's where you do sometimes have to bring out the wedges. So you'll notice on some of my Bioclear cases, I'll use wedges, some of I won't. It really just depends what the teeth give me. And my main thing is, can I predictably hold everything in place and know that at the apical extent, it's going to be well sealed? And in this case, everything looks fantastic here. So what we're doing is just doing the etch as normal. Will be pretty much as the system goes. So that's the beautiful part about this. Once you get it all set up, it's very predictable. You can get beautiful results very efficiently, kind of efficiently, depending on how easy the matrices are to get off. But you can get them to where if I tried to do this with, say, like Mylar or wooden wedges, it wouldn't look as good. And that's because the hardest part for me to do generally are those embrasures, both the incisal and the apical, and especially the apical ones here. They're done for you. You'll see I pretty much don't have to touch those whatsoever because the matrices do it for you, and it creates this really nice shape in the coronal embrasure as well, making it very predictable to shape everything. Once again, if you are a dental student watching this, pay attention in dental anatomy. It is incredibly important. This is where I learned all of this. That's actually one of my favorite classes. I think it's just because the waxing stuff was kind of fun to do. I'm weird like that, but I found that to be a really enjoyable part of it. But pay attention, because this will all help you later, regardless of where you end up. If you're going into, say, surgery, whether it's perio or oral surgery, knowing how the embrasures work depending on how deep you place the implant is an example of this. If you're in ortho, of course this is important. If you're in general, of course this is important. And even as I'm showing in endo, if you have to restore teeth like this, which you should if you're an endodontist, it is very important to make sure that you have the best possible outcome for the patient and for the referring office. So same thing as before, just making sure everything is well sealed. What I'm checking here is sometimes on anterior teeth, I will actually do 2 cures if the coronal aspect of the matrices are almost collapsing too much. And that's what I was trying to see is everything going to hold in place? Is it going to be in the proper position? And this is the one thing I do find a little bit awkward is when you go to light cure it, you do have to kind of hold I feel like I'm, torturing the poor tooth by holding it in so many different areas with, my hand, with the glick, with everything. You'll notice the tooth looks really gray there, and that is because of the bonding agent. The bonding agent has that yellowness to it. As soon as I get the matrices off, you'll see the tooth is nice and white. We'd used shade A1 for all of these. That was when I took Clark's course, a few years ago. Oh, that one came off easily. So let's see. We do have, it didn't come off easily. Never mind. I tricked myself there. That's good. There we go. Now it came off easily. But so sometimes they do that's what it should look like, everybody. That's what it should look like. If I remember correctly from this, it's been a minute since I did the initial edits on here. I don't think I have as much luck with the mesial. Nope, yeah, grabbing the burr. And that's just because the composite kind of looped over it and locked it in place. So that's what I'm doing here is just smoothing this out so I can remove that matrix a little bit more efficiently and actually just remove it, period. It doesn't matter about efficiency at this point. And get that all out of there. Anyway, that yellowness that you see, that is from the excess bonding agent that's inside there. It's going to be prepped off and we'll clean it all off. And then as I was saying, when I took the course initially, Dr. Clark recommended just using A1 body for pretty much every patient. It matches nicely with most teeth, and if it is a little bit darker, oftentimes they'll be very pleased with it, because that was another pro tip I always learned. Never make teeth darker, always make them lighter. If you're between 2 shades, always choose the brighter one. The patient can always bleach to move up. Obviously, if they have crowns or something, that's a different deal. But for people who are aesthetically driven, make them brighter. They'll be happy, I promise. As you can see, I'm struggling with this one. So 3 out of the 4, we had problems on the matrix getting everything out. Don't know why it was so difficult for these. Once again, if you know, please drop a comment below and let me know. But at this point, we're pretty much getting ready to finalize the polish and everything. So the first thing I'm going to do is set my incisal edges. You'll notice on tooth number 8, he did have a little bit of chipping. I don't know if it was a mamelon, if it was a chip from the trauma. Regardless, I'm going to make it so that the front 4 teeth look as perfect as possible here. I also didn't like that little spot on number 7, so we're going to improve that just ever so slightly. And patients are generally totally happy. If you make them look better, no one's going to be upset. You can, if they have don't close diastemas without asking them, because a lot of people prefer to have that. But if there's chips or things like that, it takes 2 seconds to quick smooth it off and make the teeth all look symmetrical, and they'll be far happier. This guy left very, very pleased with the treatment, because as you'll see, he walked in with no teeth and walked out with teeth that looked better than he had even before the trauma. So I'm going to do the bulk of the removal, doing my shaping of the apical kind of emergence profile from the buccal first, because that gives me the shape. And I do it with rubber dam on, because if there's any issues, like did I underfill an area, is there a void, then I can still fix it with the rubber dam on. Once we get it to where the shape's looking great, then we will remove the rubber dam so I can look at their face to do the final polish. And what I'm doing with my hand there, I'm not wiping, I'm actually feeling with the tooth next to it. Does 8 feel the same as number 9? Do I have the same kind of, emergence profile on the two teeth. You want to make 8 and 9 look as symmetrical as possible. You can play around with laterals. Laterals are, you know, they're kind of fun. I remember a old school prosthodontist telling me how much he loved doing dentures with laterals because you can give them a little bit of character. You can make them look, not quite perfect, and no one's going to care. And guess what? There's still another piece of the matrix in there. So if you ever lost a contact, if you've never worn contacts and don't know what it's like this when you break a contact in your eye. It's the worst thing in the world. So at this point, everything's looking great, and we're just going to pull off that rubber dam. I didn't use any clamps or anything for this. He had nice tight embrasures, and so I was able to floss everything in. So what we're going to do now is, guess what? There's more matrix to remove. I swear, I don't know why they were so stuck on here. It's absolutely wild, but you can see it's pretty tight in between there. Which is good. We had a good tight fit, and we were able to pop that off. Okay, so at this point, I have left number 9 slightly long because I wanted to see with where his face is and with his eyes, does everything look properly? And now I'm measuring, and you can see I'm taking away quite a bit on number 10 because I left that one long as well. And I'm going to give it a similar shape. So you can see it's not completely flat. It almost has a nice little curve to it, as the 7 does. So want to make sure those two match, at least, pretty darn closely. And at this point, we're starting to get some decent looking teeth. So the way that you really get them in is that the final little bit, making sure everything is as, you'll see me do some fine tuning here, but you do want to do the bulk removal now with a larger burr to make sure that everything looks as similar as possible. You'll see me pause and check the opposing tooth. So this is far easier when you have to just do everything from scratch. You can kind of just, make it your own. But if you're trying to match teeth, do a little bit, check, do a little bit, check. You want to keep going back and forth. And that's why even from the very beginning, I made the rubber dam a little bit larger so I could see what was going on. For the incisal embrasures, I'm going to use this skinny diamond here. It's an absolutely fantastic one. Sometimes I'll use the mosquito, but I find that this is almost like my all-in-one polishing burr. It is a yellow stripe, so it is fine. It does a really nice job getting that initial polish, and then I'll come in with some polishing compounds to do the final one here. But you'll notice there are 2 kind of line angles that you have to work for on all the teeth. If you're in dental school and haven't taken dental anatomy, in general, you're going to have 2 angles on incisors. You're going to have the apical one, which is going to be more upright, and then most people's teeth kind of curve back towards the palatal. So you'll notice I'm having almost a straight up and down right here when I work on the apical region, and then as we go towards the incisal edge, I'll tilt it back a little bit. And so same thing here, just checking with the opposing tooth. You want to make sure that they're as close as possible. He also was pretty young, so he had some decent developmental grooves in here, and you do want to match those. You can almost see the light from the microscope shining off of there on number 8, and I kind of made sure that we had some exaggerated grooves. I leave them a little bit rough because when I go in with the polishing, you want to make the developmental grooves a little bit deeper. And it's okay to leave them rough because when you go in for the final polish, it will soften those grooves and get rid of those spots. But it really catches the eye nicely when they have those little spots inside there. Now what I'm doing is polishing the palatal. I knew this was going to be a fun one, and my nice skinny diamond was able to get farther down inside there. You can tell it's going to be a little bit rough back there, but I think it's going to be totally fine. Obviously, with any trauma case, follow-up is super important, so I will do my best to remember to take some photos of the tissue and post them when we see the patient again. But having called him, we're almost a month out from there, so we should be actually seeing him pretty soon. I got to check the schedule. Thanks for reminding me of that, Scott. Having been a month out, he was fine day 1 post-op when we did the post-op call, and we will be seeing him shortly to make sure these teeth are still vital. Everything's looking good, but in general, no news is good news when it comes to these cases because they tend to be pretty obvious with pain or with discoloration, things like that. And yeah, that's pretty much it when it comes to that. So I am doing a little bit more work on the palatal here. For some reason, I believe I said this earlier in the video, the composite tends to pool more on the lingual side, and so that's why you'll see me kind of take my finger from the palatal, push it forward, and you tend to have to remove a little bit more composite on this side in general. So that's why I'm pulling out that big barrel burr. This is a fantastic burr. I wish we had this in dental school. I don't know why we didn't. This is an absolutely amazing burr. It does a great job with crown preparations, with smoothing off rough edges, and it does a great job with creating the cingulum shape as well. So one of my absolute favorite burrs. I like it way more than a football burr, which is what we used in school. It does a nice job kind of smoothing or creating those shapes. So finalizing the lingual here. I know I said I don't spend as much time on the lingual, but in this case, it was important to me to make sure we had a nice smooth emergence profile so the gingiva would look good. At this point, we are testing the bite here. You can see me kind of shaking him to see if he goes back into CR. He does not. So that probably explains he didn't have any protection from his lower teeth, which is why the trauma was so bad. He is a little bit class 3. We're doing the final polish here with the Bioclear Rockstar polish. If you've met David Clark, he's a fantastic human being and has all the energy in the world. So of course his thing is called the Rockstar polish, but this stuff really does work well. You can see those developmental grooves showing through really nicely. And what the technique is, you pretty much get the shape done, get the polish done, and then once the Rockstar polish is on, you can see if there's any areas you have to polish up a little bit more. When I first started doing it, I didn't get as much polish done before using the paste. So you want them to be pretty darn close to done, and then you can just get them to really shine up here. This is the final Rockstar polisher. This thing works extremely well. You do have to put a lot of pressure on this. This is one of the things I wasn't doing initially. So you'll see there's squirting water in there, and that's because I'm pushing pretty darn hard. It's about 4 pounds of pressure, which is the same amount that we use to check for trigger points, which is quite a lot of pressure, actually. I like to look at the teeth both wet and dry, and there you go. Good looking teeth, really pleased with the result on there. That's how we did it. That's what everything looks like with the direct pulp caps. You can see the composite looks really nice as well. And just a reminder, here's where we started, here's where we ended up. So patient was very pleased. Hopefully that was a great video for all of you. If you have any questions, please drop them down below. Thank you all so much for watching, and I will talk to you all next time.